We are going to discuss the systematic approach for evaluation of cervical lymph nodes in head and neck cancer. الغرض من المحاضرة مش ان احنا نقول معلومة جديدة او يعني something new. انا بس عايزين نعمل مع بعض شوية objective، نعرف الobjective بتاعنا من المحاضرة قبل ما نبتدي. أول حاجة إن my lecture is based upon an article published on American Journal of Radiology on 2013 about evaluation of cervical lymph nodes in head and neck cancer with CT and MRI, TEPS, TREPS, and a systematic approach. The objective of my lecture is to create a mind map for evaluating lymph nodes in the setting of head and neck squamous cell carcinoma and thyroid carcinoma, and highlight important TEPS and TREPS. Why this is important? Because the presence and extent of nodal metastasis in head and neck cancer has a great impact on treatment and on prognosis. So the target of the lecture is to create a mind map of how to approach the lymph nodes in the setting of cancer. So they stated a four-step approach to evaluating lymph nodes. We have 4 steps. The first one is to know the criteria of abnormal lymph nodes, then make a site classification, check the drainage site, and then say check for features of staging and features for important for management. So all those data you are supposed to know. All we have to do is enumerate them in our mind. First of all, we have this question. Just keep the answer in your mind. Is this lymph node normal or pathological? This one on the right side with the yellow arrow. Okay? We will now check how to assess to know this is normal or abnormal. So we will go for step 1, the criteria for abnormal lymph nodes. So we have to go on this circle: size, morphology, shape, margin, and distribution. As for the size, the method of measuring lymph nodes is a source of variation. But finally, response evaluation criteria in solid tumors 101 measures lymph nodes in the short axis on axial image. So we will go to do the measures as stated, short axis on axial image. What about the size criteria? This is variable. It ranges from 7 millimeter to 3 centimeter, but Curtin et al. Found that 1 centimeter size achieved 88% sensitivity and 39% specificity, where 1.5 centimeters gives 56 sensitivity and 84 specificity. With making a comparison, 1 centimeter gives a higher sensitivity than the 1.5 centimeter. And this is much more important in head and neck to get the sensitivity higher than the specificity. So we will go for 1 centimeter. So what's the trap about the size? We don't need to be trapped like this line. Nodes less than 1 centimeter can still be malignant, so you have to check for other features. So don't make your assessment only based on the site. Search for other features in case you know that you have a primary, okay? And in case if you are searching on the drainage pathway of the tumor, like this, we have a pathological lymph node on the left side, and it is enlarged. On the right side, there is one which is small, but don't say it is normal because it has a regular shape and surrounded by fat stranding. So this is the trap that we have to check for smaller size lymph nodes. So what's the helpful tip? What we can do? We can do other imaging modalities like PET-CT, and here we can see that both lymph nodes are active. That means both of them are infiltrated by cancer. The next, after the size, we have to assess for the morphology. Metastatic disease can replace the normal fatty hyla with necrosis, calcification, and hyperenhancement. It is the most valuable sign to find a necrotic lymph node. This is a sure sign, 95% up to 100% for malignancy. So this one shows a necrotic center. So if we have a primary, we go for metastatic lymph nodes. Primary site to consider with cystic morphology are papillary thyroid cancer and oropharyngeal head and neck squamous cell carcinoma. So if you are not aware about the primary and you found a necrotic enlarged lymph node, you have to think of those 2 primary sites and search for the tumor. The next trap, don't dismiss cystic neck lesions as congenital cysts in adults. You have to give more concern about this. The helpful tip about the calcification. Usually on the mediastinal nodes, calcification is a sign of benignicity. But in cervical lymph nodes, calcification is not a good sign. It's more frequently seen with malignancy. So when we see necrosis, we have to think about metastatic lymph nodes, and when we see calcifications in the lymph node, we have to be suspicious. What's the trap about necrosis in the lymph node? Partial volume artifact of normal fatty hyla may mimic the nodal necrosis. Here we can see a 75-year-old man with invasive squamous carcinoma of the left tonsil. CT was performed for nodal staging. What we find multiple amalgamated lymph nodes on the left side, and a small, it was reported firstly as a necrotic lymph node on the right side. But more reformatted CT images and complementary ultrasound revealed a normal lymph node with normal fatty hilum. So they just do a reconstruction and ultrasound, which confirmed that it is a benign lymph node and not a malignant one. So the next is the assessment of the margin and the shape. So we go first for the size, morphology, and then margin and shape. A normal lymph node has a reniform shape and smooth, well-defined margins, like this one. So we have to check for the shape and make sure that the margins are clear, because the signs of malignant infiltration are one of two: change of the shape and interrupted margins. If we have a look here, it becomes rounded, no more reniform. The margins are interrupted and surrounded by fatty stranding. That means there's external or extracapsular infiltration of the surrounding fat planes. The trap about this is recent lymph node biopsy or radiation may result in inflammation and ill-defined margin that can mimic extracapsular spread. So if the lymph node is biopsied or there is previous radiation, we have to think that it does not mean that it's always malignant. We have to return to the history to make this differential diagnosis. What about the distribution? Suspicious distribution of the lymph nodes includes symmetrically prominent lymph node like this one. This one is enlarged compared to the other side. Confluent lymph nodes is not a nice sign along the drainage pathway of the primary tumor. Those are the suspicious distributions of lymph nodes. So back to the question, is this lymph node normal or pathological? So you will go to the assessment of the 5 criteria. What about the size? Enlarged. What about the morphology? Necrotic. What about the shape and the margin? The shape, it becomes rounded and the margins are irregular and surrounded by infiltration, and distribution, it is asymmetrically enlarged compared to the other side. So this is a pathological lymph node, not a normal one. So this is the first step. You know the criteria for abnormal lymph nodes. The next step, when you find an abnormal lymph node, you have to cite the classification and check the drainage site. What is the level of this enlarged lymph node in a patient with tongue-based carcinoma? This one, and keep the answer in your mind. So I said it is abnormal because it is enlarged and has a necrotic center, okay? It lost its normal shape, okay? Asymmetrically enlarged compared to the other side, so it is abnormal lymph node. So we go to the next, we need to do leveling. Sorry. Once we pick an abnormal lymph node, first we have to classify to a site on basis of system devised by the American Head and Neck Society, American Academy of Otolaryngology, and the Head and Neck Surgery. So the sites of classifications, at first they make 7 levels. The first level is the submental and submandibular, okay? Then 2, 3, and 4 are along the internal jugular vein. 5, the posterior triangle of the neck. And 6, the pretracheal, prethyroidal, precricoidal. And 7 is the superior mediastinum. Then we have the retropharyngeal, parotid, and supraclavicular fossa. They are not integrated on this system, so you have to be aware to search for them away from those 7 levels. Before doing the leveling, you have to know the important structures that separate the nodal levels. So you have to figure out their anatomy. The hyoid bone, the cricoid cartilage, submandibular gland, sternocleidomastoid muscle, anterior pili of the gastric muscle, and the sternal notch of the manubrium. This is a coronal CT image, okay? We are figuring the levels of 2, 3, and 4. Those are along the internal jugular vein. So we have to figure out the internal jugular vein. Then we have to search for the lymph nodes along this pathway. What makes the level? We take a transverse line at the level of hyoid bone. Okay, above this line is group 2, level 2. Below this line is level 3 until the inferior border of the cricoid bone. Below this is 4. So 2, 3, and 4 are separated by transverse line at the level of hyoid bone and cricoid bone. So if we are on the suprahyoid neck, we can assess level 1, 2, 3, and 5. What's the lines of separation? We have to figure the landmarks at first. It's suprahyoid. Then we have, this is the submandibular gland, internal jugular vein, and sternocleidomastoid muscle. Okay? This is the landmarks at first. Submandibular gland, internal jugular vein, and sternocleidomastoid muscle. So then we take a transverse line behind the submandibular gland and behind the sternocleidomastoid muscle. So anterior to this line is 1P, and posterior to it is 2. Until the posterior end of the sternocleidomastoid, behind it is 5. Then we come to the internal jugular vein. What's anterior to it or beside it is 2A, and what's posterior is 2B, okay? So again, the landmarks, submandibular gland, internal jugular vein, and the sternocleidomastoid muscles. And we take the posterior lines to make those separations. 1P, 2A, 2B, and 5. We go at the level of the hyoid bone. So we search for the landmarks at first. So this is the hyoid bone, okay? Submandibular gland, sternocleidomastoid muscles, and internal jugular vein. So we make the landmarks at first, the hyoid bone, so we know the level, where are we staying. Then the same landmarks, submandibular, sternocleidomastoid muscle, and internal jugular vein. So what's behind the sternocleidomastoid muscle is group 5. What's between the sternocleidomastoid and the posterior aspect of the submandibular gland? It is 2A and 2B separated by internal jugular vein. Okay, what's anterior to the submandibular gland is 1P, and when we can see the anterior belly of the gastric muscles, so between them, its medial borders, it is 1A. Okay, it is the same as before, but we added 1A to the categorization. So when we go to the infrahyoid neck, we can assess other groups, 4, 5, and 6. We do the same. We have, this is the sternocleidomastoid muscle, but it has a more transverse orientation. So we take a line from the posterior aspect of the sternocleidomastoid muscle to the scalene muscle here. What's posterior to it is group 5, and what is between the sternocleidomastoid muscle and the medial aspect of the carotid artery is group 4, okay? And what is here is group 6, okay? So the first line between the sternocleidomastoid muscle and the scalene muscle, and the other line is along the medial aspect of the internal carotid artery. So in between the two lines is 6, this group are 4, and this one is 5. Okay, this is about the leveling. After you finish checking those levels, you have to check the drainage sites of head and neck carcinoma. So each tumor have a drainage pathway of lymph nodes. When you know this pathway, you can know where to search. So for example, oral cavity drains to level 1 and 2 and 3. So what about nasopharyngeal carcinoma? It drains from 2 to 5. So when you do the leveling and you know that this case is a nasopharyngeal carcinoma, you go and be concise to check for retropharyngeal lymph nodes, because you know that this tumor drains to this group of lymph nodes. So you will not miss. When you have a checklist, you will not miss. Oropharynx drains to level 2 and 3 and retropharyngeal, so you know where to search, okay? Hypopharynx, the same, larynx, and drains to other groups of lymph node. When you know each tumor and its drainage pathway, you will not miss a lymph node metastasis. What's a helpful tip? Like this one. This is a squamous cell carcinoma of the pharynx. There is a large mass, and it makes a metastasis to the retropharyngeal lymph nodes, where there is posterior pharyngeal wall involvement. So when I know there is a mass, so they send for CT for staging. We can find necrotic lymph node on the left side, enlarged lymph node on this group 2, Okay, and when I know this is a squamous cell carcinoma, I have to search for retropharyngeal group. And when I go there, I can find this lymph node. This can be missed unless I know my pathway and where to search for lymph nodes in the metastasis. Okay. So why you should know drainage sites? It has many benefits. When we have unknown primary, so when we know the drainage sites, we can expect the primary. We make it retrograde. Okay. Midline tumors like nasopharyngeal carcinoma, epiglottic, and oral cavity tumors frequently drain bilaterally. And when you know this, you go and search on the left and right side. If a lower level neck node is detected, which is obvious and large, you have to search for higher level and check carefully for this. So this is the advantages of knowing the drainage site of each tumor. And if you don't know at the time of reporting, we can Google it. So back to the question, what is the level of this enlarged lymph node in a patient with tongue-based carcinoma? 2. Right, 2. This is the submandibular gland and this is the sternocleidomastoid muscle. When I take a line here and a line here, so we are in group 2. The third step, we have to check for features important for staging. We know the lymph node and we know its location, so we have to know what we need for proper staging of the cancer. The final end stage is a combination of clinical examination, imaging, and pathology. What's the rule of radiologist? We have to know 3 items. We have to know about the size of the lymph node, we have to know single versus multiple nodes, and we have to know about the size of nodes. This makes a difference in the staging. When you say it is a small or then 3 or 7, it has a difference, then it is larger. When we say it is a single lymph node, it is different in staging than multiple, and the side, ipsilateral or bilateral lymph node. This may alter the staging and subsequently alter the treatment procedures after that. So look for small metastases that will upstage the lymph nodes. What's nice about these steps that we usually are attracted by large pathology. We got trapped by the large mass, the large lymph node, and we keep measuring them and writing their criteria. But when we know those steps, we have to know that don't be trapped by the large pathology. Start searching for small metastases that will upstage the end staging. If there is a single lymph node, search for another one. If there is ipsilateral disease, evaluate the contralateral nodes. Those are the 3 items: size, single versus multiple, and finally bilaterality, right and left or right or left. If there are no clearly abnormal lymph nodes, carefully re-examine the expected first order draining nodes. This is back to knowing the drainage site about the tumor. Maybe for the first glance at the images, you didn't detect a lymph node. But when you know the drainage site, you go and specifically check on these sites, okay? The last step we're going to discuss, the features important for management, okay? I guess I'm okay with the time, right? Features important for management. Lymph node metastases are the most important independent prognostic factors in head and neck carcinoma. So we have to check of the local invasion from lymph nodes that first occurred beyond the nodal capsule and then into the adjacent structures. So the extracapsular spread we discussed during the morphology. To check for this, you have to check around the lymph node and its borders. This mostly happen in nodes larger than 3 centimeters, but in some cases it can happen in smaller lymph nodes. As we mentioned earlier, it's not the size that does not determine if it is metastatic or not. Sometimes benign lymph nodes is very large and metastatic lymph nodes can be small, okay? So nodal metastasis can invade the capsule and comes out, invades the muscle, the bone, neural and vascular structures. So we have to assess for all of this: muscle, bone, neural, vascular structures. So like this one, okay, we have an intraparotid large lymph node, metastatic lymph node. We cannot find a clear cleavage between the node and the sternocleidomastoid muscle, impressive of invasion of the muscle, okay? There is destruction of the bone, invasion of the bone. And if we make a bone window, it will be much more clear than this. And the stylomastoid foramen, impressive of perineural spread. So when you are minded that external spread can occur from the lymph node, you can know what to assess and what to search for. The arterial invasion affects the surgical option later on, so we have to assess this large lymph node, which make an invasion to the muscle, okay, and invasion of the artery. So how we can assess the invasion of the artery? There are multiple criteria: narrowing of the artery, encasing of the artery, regularity of the artery, and this may alter the surgical procedures or lead to other complications. So it has to be reported that this lymph node happens to invade the surrounding structures, okay? So finally, the take-home message, which I care about, that in radiology, systematic approach is the key for adequate diagnosis. Usually, we have all fallacies and we can make wrong diagnosis. I usually think that we can limit this by making a mind map about each topic we are dealing with and taking proper history whenever it is possible, because this will lead you to the direction of proper diagnosis. So again, for the systematic approach, we assess for the criteria of abnormal lymph node. We know about the leveling, the drainage sites, then what's important for staging or what makes the difference, and features important for the management. And let me thank you for this. I usually, at the end of my lectures, I used quotes. So my favorite one for this one is, develop a passion for learning, and if you do, you will never cease to grow. I know it's tough to keep learning, especially here in Egypt, but when you develop a passion, you can still do well. This can be applied to learning anything, not only radiology. We can do this in everyday life. And those images are the goal values of our classroom. If you have a look in our booth, we depend on passing education to people. We depend mainly on volunteering. This is a non-profit project. We're not leading a company or something like this. We depend about motivation. We do this, invest in ourselves and on our colleagues. We are commitment, not because we are a volunteering group, that means we can produce something of low quality. We are committed to give something special and of a good level. Teamwork is my core value. I cannot work without my team, which I am very proud, and I am indeed thankful for them for the high performance they do to make this event successful. And finally, innovation. It's important when you teach anybody something to innovate something new in order to attract them. And you can go to our website, manalclassroom.com. And we were very thankful for Dr. Mukherjee because he approved to publish the lectures of this day on our website. So when, once we are done with the processing, we will publish them on the website for free. Okay, thank you for this.